checking to see if we are recording this session. Probably not a bad idea. Yep, we are indeed. So just wanted to let everyone know that this session is being recorded. So welcome everyone. Welcome to the third and final CFAR sponsored HEIST workshop of the academic year 2020-21. My name is Carol Levin. I am a health economist and a clinical associate professor in the Department of Global Health. I'm also a co-chair of HEIST, Health Economics, Impact Studies for Translation. And we're delighted to have you joining today. In October, we had a HEIST workshop titled Preparing Yourself for Health Economics Research in 2021. In March, March in 2021, we hosted a workshop on mathematical modeling of infectious diseases. And today we're exploring costs for use in economic evaluation and budget impact analysis. So for those of you who are joining us for the first time, perhaps you could raise your hand if you're new to a HEIST workshop, or if you have not attended any of the previous workshops. We would really appreciate it if you just raise your hand. Welcome. And perhaps you're not familiar with what HEIST is. It is both sponsored by CFAR and the Department of Global Health, and we're a group of health economists and modelers who support other researchers, whether you're faculty, staff, or graduate student, with the tools to evaluate cost and cost effectiveness of HIV/AIDS prevention and treatment, cardiovascular disease, tuberculosis, and a wide range of mental health, a wide range of conditions that we address in global health. We are here to help support academics and experts. We have expertise in health economics, mathematical modeling, epidemiology, clinical trials, infectious disease, health metrics. So our goal is to help you to incorporate health economic evaluations into your own work, rather than that being in an exception in study development. So we will be providing a link to the CFAR website, and you can access materials from today's workshop as well as materials from the previous two workshops. So today it's my pleasure to share the agenda with you. I'll let you look this over while I introduce our speakers. We are really lucky to have Marcia Weaver, an economist and a research professor in global health, as well as research professor in health metrics sciences and an adjunct research professor in global health. Marcia has been conducting economic analysis in a wide range of really interesting topics, and she'll be giving an overview of costing today, as well as sharing some of her work and an application on microcosting. Then we'll hear from Sarah Masyuko, who recently graduated from the PhD in global health in our implementation science program. She's currently a postdoc scholar in the Department of Global Health, working on HIV and non-communicable diseases. And she also works for Kenya's Ministry of Health, their HIV program. And our third speaker of the day will be Mita Sahu. She's a second-year PhD student in global health metrics, working primarily at the Institute for Health Metrics and Evaluation, estimating health spending in the US. But today she's going to present work that she did with the Department of Global Health with Ruan Barnabas's group on cost effectiveness of community HIV care. Ruan Barnabas, who is a co-chair of HEIST as well, is unable to join us today because she's probably taking a well-deserved vacation with her family. She's on leave. So let me stop there and welcome you all. I'd like to invite Marcia to now share her screen and give the first session presentation on an overview of costing methods. Thanks, Marcia.
Sorry, Marcia, I think you're on mute.
Is that better? Okay, for those of you who attended the October workshop, this will be a review of Carol's introduction. And for those of you who didn't attend the October workshop, it will be a brief introduction. So when we conduct a costing analysis, we are trying to estimate the cost of producing a health service. It requires a measurement of the amount of each resource used, as well as information about the price or value of each resource. And as this figure shows, the type of resources that are used to produce a health service include human resources, drugs and other supplies, and medical and non-medical equipment. When we're measuring the value, we talk about two types of costs. There are financial costs, which represent the actual expenditure on goods and services. And there are economic costs, which are defined as the opportunity cost or value of resources used to produce something. And this would apply to volunteer labor that doesn't have an expenditure, or to a donated good or service where there's no explicit expenditure for a Ministry of Health or a health facility. So this was Carol's example of an active TB case finding intervention, where she compared the financial cost of nurses who live in free nursing accommodations at a facility, where we have a budgetary expenditure for their salary and their transportation allowance, but the economic cost would be a more complete estimate of both the market value of nurses at the national level, their transportation allowance, plus the value of their accommodation. For a lay volunteer, there would be no financial cost, but we want to include the value of their time and the next best alternative use. And often we use the national average wage for an age category for that value. And then for a syringe, the price paid and the market is generally the same as the economic cost. Once we have the economic value, a unit cost approach, which is frequently used, is to take the value and multiply it by the number of units of service. So for a nurse, I've created a made-up estimate of $15 per hour. And for this particular intervention, it would require 20 hours of nurse time per month. For the lay volunteer, a national average wage of $5 per hour, they would be working 100 hours per month. This next three items are all, the value is on a per patient basis. So to get the total cost, we multiply the value by the number of units and then the total number of patients seen in a month. For the computer, we have the market price of the computer, and because it's a capital expenditure, we take the estimate of the 3-year life of the computer, and a rough idea would be about $400 per year. And in this particular case, it's used half the time for the active TB case finding intervention. So when you're conducting a cost analysis, there's you start with the scope, and the steps are to describe the intervention or program fully, to identify the activities for the intervention during a specified time period and in a specified context, to identify the inputs that are required for each activity, and then also to define the outputs for each activity. And in the TB case finding example, it's probably either number of patients screened for TB or the number of cases of TB detected. There are, for the purposes of today, we're talking about two ways of measuring resource use. There's micro costing, where You quantify and cost out every input consumed in preventing or treating a disease. So you'd have an Excel spreadsheet like the one that we just saw. Then there's a macro costing approach where you allocate the total budget to a particular department or service, and then you divide that total budget by the number of service units provided. And these two approaches are not mutually exclusive. One way of thinking about the two approaches is that macro costing, the strength is that the estimates are more likely to be generalizable. And for micro costing, the estimates are more likely to be sensitive to changes that might arise from the intervention. Of course, you could have micro costing estimates that are generalizable if you had a large representative sample of facilities from which you were collecting the estimates, but I rarely see those samples. And for macro costing, you could also have those could be sensitive to changes, but as far as I know, there are only 2 countries that produce estimates of unit costs for outpatient visits and inpatient admissions at the cause level. So it's these are some ideas of the strengths of each, but it's possible that either method could be strong enough in both of those dimensions. So one way to think about using these 2 methods in combination is a lot of times in clinical trials, there'll be quite a bit of resources devoted to estimating the costs of the intervention and doing that from a micro costing approach. And then when it comes time to estimate the cost offsets, if you have a preventive intervention that's preventing episodes or minimizing the severity, you will have fewer outpatient visits and fewer inpatient admissions. And there are rarely resources to estimate a unit cost for those outpatient visits and inpatient admissions. Just to go back, one way that I've seen these 2 methods used in the literature is to combine a micro costing approach for the intervention and then a macro costing approach for estimating the cost offsets. So I'm presenting exactly that next, and then Sarah will be presenting an excellent example of a micro costing approach for an intervention. So turning to these global estimates of the unit cost of outpatient visits and inpatient admissions, we use a mutually exclusive, collectively exhaustive account of national healthcare spending by type of care and by location. Let me just go a step back and say that one of the challenges in health economics is the absence of a price measure. In the United States, we basically the amount that's billed by a healthcare facility bears very little relationship to the amount that's paid by insurers or by patients out of pockets. So even though, so it's amazingly hard to come up with an actual price for these services. In countries with national health systems, the billing doesn't exist, and it's not easy to track funds allocated from the national level to the local governments and then to facilities. And that kind of tracking is even more difficult in resource-limited settings where the centralized personnel systems exist, so you don't even have personnel budgets at the facility level. So we're sort of trying to do this at a macro level to provide for the first time these estimates, global estimates for unit costs. So one of the principles for estimates at IHME is to have mutually exclusive, collectively exhaustive estimates. And in this case, they're coming from accounts of healthcare spending by type of care and by location. The calculation that we're aiming to provide for an outpatient visit is to take total health expenditure and multiply it by the share of outpatient expenditure in the national health accounts, and then divide it by the outpatient visits per capita multiplied by population as a measure of total of the volume of outpatient visits for a country. And then we do the same calculation for inpatient admissions. So we rely on 3 sources of data: estimates of utilization per capita by year and location. We have total health expenditure by year and location from IHME's Health Financing Global Health Team. And then we produce an estimate of the share of each service from the National Health Accounts functional categories. So as an overview of our methods, we're producing these cost estimates from the perspective of the health sector. It's a macro costing approach based on Meta-Regression analysis. Our data sources are utilization surveys and administrative data from 1990 to 2016, and total health expenditure and a national health account data from 1995 to 2016. Our sample are utilization estimates based on nationally or geographically representative surveys. The cost is for the health sector at the time of the service. So we include any drugs dispensed at an outpatient facility or at an inpatient admission. And our pricing, we present these estimates both in 2017 international dollars and in US dollars. So now I'm going to show you our estimates for utilization and for costs. So using standard GBD methods, the first step in a GBD analysis is a case definition, or in this case, a definition of what we're trying to measure. So for the outpatient utilization rate, we're looking at the annual number of outpatient visits per capita to a health facility. And the inpatient utilization rate is the annual number of inpatient admissions of 1 night or more per capita to a health facility. And then for the volume, we take the product of the utilization rate and the 2016, GBD 2016 population estimates. Here's a description of our data sources by GBD super region and by time period. As you can see, we have 1,175 sources of outpatient data from 130 countries, or exactly 2/3 of our sample of the 195 countries for which we produce estimates. We have inpatient data from 2,068 sources from 128 countries, so just under 2/3. For those 130 countries with outpatient sources, we have on average 9 country years of data. And for the 128 countries with inpatient sources, we have on average 21 years of data, country years of data. Overall, 59% of the data are administrative, but for most of the super regions, the majority of the data are actually coming from surveys. And similarly for inpatient data, 90.3% of the data are from, or I'm sorry, 80.3% of the data are administrative, but from Latin America and the Caribbean, Southeast Asia, East Asia and Oceania, North Africa and the Middle East. Most of the super regions, the data are actually, the majority of the data are coming from surveys. The challenge that these more than 3,000 data sources are heterogeneous. So the challenge in our estimates is to accommodate the different types of data. both survey and administrative data. Which they basically range from microdata on individuals to an average reported in a PDF. So then we also need to generate estimates in countries where we have no data, and then to reconcile differences in the data. Differences basically in the administrative records and surveys. For the surveys, we have different recall periods. So some surveys may ask, how many outpatient visits did you have in the last year? Which is going to be pretty challenging for most people to recall accurately. Whereas others might ask about outpatient visits in the last 3 months or the last month or 2 weeks, where we believe we have more reliable data. And then we also want to account for different age patterns of utilization that follow often the age patterns for health. So our solution to these methodological challenges is to use Bayesian hierarchical meta-regression methods. And these methods are described in a book by A.B. Flaxman, Theo Voss, and Chris Murray, called Integrated Meta-Regression Framework for Descriptive Epidemiology. I can break this down where meta-regression combines a meta-analysis with a regression. So on the left, you see a standard meta-analysis where you're combining data from multiple studies to get a larger sample and more precise estimate. In this case, it's an estimate of an odds ratio. But on the right, if you have those same multiple studies across spanning multiple age categories, there might be a relationship between that odds ratio and age. So you conduct a meta-regression analysis to see how that parameter varies with age. The Bayesian hierarchy means it's based on the idea that locations are most like their neighbors. And so we can borrow strength both in space and time from neighboring locations. So, and the estimates for locations without data are driven by a Bayesian prior and country level covariates. So in our hierarchical model, we start with a global estimate, which then becomes a prior for an estimate in GBD's 7 super regions, shown here as step 2. And then those super region estimates are the prior for the regional estimates in GBD's 21 regions. And then the regional estimates become the priors for the national level estimates. The covariates that we use for the utilization estimates is the sociodemographic index for the outpatient model, which combines the global, gross national product per capita with fertility and educational attainment for people 15 and older. For the inpatient model, our country level covariate are beds per capita. So these are our results by age category. And beginning on the right, you see the outpatient utilization rate in 2016 for females. And the black line represents the global average. So it starts at about 5 visits per person per year for newborns. The number of visits dips somewhat among older children, and then for females rises during reproductive years. The slopes kind of decreases after reproductive years and levels out among the elderly. In contrast, for men, we see a fairly steady decline from newborns to older children and early adulthood, a fairly steep increase at around age 50 for many super regions. And then when we look at the far right at the ratio of male to female utilization, you see a fairly clear pattern of higher outpatient utilization among females during reproductive years, and then a somewhat lower utilization rate among the elderly. So to produce the national estimates, we multiply the utilization rate by each age category in a country times a standard share of that age in total population. And we get these age standardized outpatient visits per capita globally. And you can see, well, there's on average globally 5.42 outpatient visits per capita. And that ranges from a high of 19 visits per person in Taiwan and 17 visits per person in Japan, to a low of 1.5 visits per person in both Haiti and Ethiopia. We also have estimates for a 27-year period. So to summarize how utilization has changed over that 27-year period, the number of outpatient visits increased from 25 billion in 1990 to 39 billion in 2016. And we decompose this change in about a 59% increase in the number of visits. And that's decomposed into 43% from population growth and an 8 each from population aging and increases in utilization. So in this figure, you can see for high-income countries, there was a slight increase in hospital visits from population growth and aging that was offset by a decrease in, in outpatient visits utilization rate. For Southeast Asia, East Asia, and Oceania, you can see that there was actually a larger increase in visits coming from utilization rates, an increase in utilization rates, than from increases in population growth or aging. And then in sub-Saharan Africa, most of the growth in utilization was from population growth. So turning now to the same estimates for inpatient admissions, we see a kind of bigger spike for women on the left, with a peaking at around age 25 for during reproductive years, and fairly level utilization among men from older children through most of middle age. And then when we look at the ratio of female to male utilization, that spike in inpatient utilization during reproductive years is fairly clear, especially in South Asia and Latin America and the Caribbean. Globally, on average, there is 0.1 inpatient admissions per person in 2016. So 1 out of every 10 people has an inpatient admission. That's highest in Eastern Europe at 0.23 admissions per person, and Central Europe at 0.18 admissions per person. And then lowest in Southeast Asia with 0.03 admissions per person, and Eastern Sub-Saharan Africa at 0.05 admissions per person. And then when we look at the decomposition of the changes over that 27-year period, for the inpatient volume increased from 420 million admissions in 1990 to 710 million admissions in 2016. And of this 68% change, 44% was from population growth, 10% was from population aging, and 14% was from increases in utilization rate. Similar to outpatient visits, for inpatient admissions, we see that for high-income countries, a small increase from population growth and aging is offset by a decrease in utilization rates. And then for Southeast Asia, East Asia, and Oceania, there was just a really boom in the number of in utilization of inpatient admissions, which is just pretty staggering, more than a 250% increase, much larger than the increases from population growth and aging. So turning now to our cost estimates, we use the national health accounts to the functional categories. National health accounts are kind of sliced and diced 3 different ways. And we use the estimates for curative and rehabilitative care for each of the services. We looked at different levels of aggregation in the national health accounts, and there was kind of a trade-off between the sample size versus the level of detail. So some national accounts are much more detailed than others. And if we wanted to rely on those more detailed categories, we eliminated a big chunk of our sample. So we opted for this fairly high level of aggregation in order to have the largest possible sample. So our sample of national health accounts, we had 795 to work with through 2016, and they represented 56% of the 195 countries. As you can see, 79% of the countries in the high-income superregion were represented, compared to only 29% in North Africa and the Middle East. We did the estimates with 3 logit transformed shares of total health expenditure using a linear regression model based on GDP per capita. So the shares were outpatient visits, inpatient admissions, and other, and they had to sum to 1. And you can see from our results for Southeast Asia, East Asia, and Oceania, the shares are the same. Whereas for Central Europe, Eastern Europe, and Central Asia, the share of inpatient admissions is larger than outpatient visits. And the opposite is true for Sub-Saharan Africa. Here we have summarized the superregion estimates of the unit costs, and beginning with Southeast Asia, East Asia, and Oceania, the mean cost of an outpatient visit is $41, and an inpatient admission is $2,229. The highest estimate is for high-income countries at $210 per outpatient visit, and $3,378 per inpatient admission. And then the lowest outpatient cost is for South Asia at $19, and the lowest inpatient admission is $477 in Sub-Saharan Africa. We have these data by country and by year, but I'm not going to go into those details right now. There are 2 other attempts to estimate unit costs, and the most widely used are the WHO choice unit costs. And we sought to compare our estimates to the WHO choice estimates. Their estimates are from 2008. So we, inflated the cost to $2,010 and then compared them to our 2010 estimates. And you can see the horizontal axis is the IHME unit cost, and the vertical axis is the IHME unit cost, and the horizontal axis are the WHO choice unit costs. So for outpatient visits, our costs are, unit cost estimates are about double the WHO choice estimates for a 2nd-level hospital. And so, which is their highest cost estimate for the most expensive facility, whereas ours is the average over all facilities. So our estimates would be, even higher if we were to average the unit costs across all three of their estimates. For inpatient admissions, our unit cost estimates are similar to the WHO choice estimates for a teaching hospital. So again, if we were to look at the average across all of theirs, we would find that our estimates in general were higher. And I think one of the consequences of using WHO estimates is that you would tend to underestimate the cost offsets of a preventive intervention. If you're saving visits or admissions, WHO choice won't capture those benefits as accurately as I think our estimates will. So I'm hoping that you'll be able to use these cost estimates, especially to estimate cost offsets in a trial. If you can collect data on the number of units of services from surveys or other methods, then you can multiply those service units by our unit cost estimates. And that's a fairly efficient way to conduct that analysis. We also produced forecasts for these costs from 2017 to 2040, and I'm especially excited about having these forecasts available. Much of cost effectiveness analysis is conducted in the past when decisions have already been made, and I'm hoping that there'll be more estimates conducted in the future so that we can inform decisions. What I presented today is reported in a Lancet Global Public Health article, and then all of the estimates are available publicly through the Global Health Data Exchange. And here's the listing and the files that have the utilization results, as well as the unit cost estimates. And then let me conclude by thanking the co-authors who worked for years to produce these results.
Thank you, Marcia. Thank you for super interesting the quick overview on costing, and then this detailed overview of the work that you've done for producing unit costs. I'm inviting people to post a question in the chat box for Marcia. We have about 5 minutes. In the meantime, I do have a question, and I think I know the answer, but I just want to make sure our viewers know. Marcia, when you refer to obtaining data from the national health accounts, is this through the World Health Organization, or where do you obtain national health account data?
So we generally do get them from the World Health Organization. Yes. Yeah.
Okay.
And they do vary in quality.
Okay. Then the other thing, I wondered if you could go back to, while we're waiting for some questions, please, there's no question that is that we shouldn't be answering here, but if you would go back to one of your slides about the use of these unit costs. And I realize that what they generate are these outpatient and inpatient unit costs for, as you say, by country over time for economic evaluations. And to date, many people relied on the World Health Organization's unit costs. So I just wanted to re-emphasize to listeners, how those can be used. Often you just don't know what the average unit cost for a visit is, and that you would use this in a very specific application, for instance, and wondered if you could say a bit about that.
So, yeah, we produced conducted a cost effectiveness analysis of a prospective Shigella vaccine. And so we were able to get estimates of the average number of outpatient visits per diarrhea episode and the average number of inpatient admissions per diarrhea episode. And then in our analysis, we looked at the number of cases of diarrhea due to Shigella that were averted due to the vaccine. And then it was fairly straightforward for us to estimate the cost offsets as the product of, for each case that was averted, the number of visits and the number of inpatient admissions that were averted.
That's so interesting. Thank you. Any questions? Because I have a couple more for Marcia because she is a font of knowledge. And then one comment. The other one, any questions? I'm looking. Do people have their hands up? Jump in. Marcia, the other question I had is, could you use these questions? So let me just make one statement. These unit costs for outpatient visits and inpatient visits are also ingredients in what we kind of call these canned models, right? So there's something that the World Health Organization and many national governments use called the One Health tool. They very much rely on unit cost estimates of inpatient, outpatients in very much the way that Marcia just described. But Marcia, could you or could these models, could you use these unit costs if you were assuming scaled up coverage, for instance, of Shigella or HIV services or TB services? How does it deal with, how would you have to adjust to account for scaling up in a low and middle income country, for instance?
So what you're thinking that the cost would change with the scale?
Well, I would think that if you were trying to introduce an intervention into a low and middle income country, you would, it may change, that's the first one, but would you have to actually add in some additional costs to account for investments to scale up, demand generation or health system strengthening? I guess that's what I'm wondering.
So I'm thinking that would come more from the intervention cost estimate, which might be more detailed. So in our case of the Shigella vaccine, we didn't use these unit costs for the Shigella vaccine per se. There's a fairly, because Carol is the most published author in vaccine cost effectiveness, there are good estimates of the cost of introducing vaccines, and we relied on those for our intervention costs.
Great. So just to be clear, then you might not use this for intervention costing.
Exactly.
Got it. Yeah. Okay. Thank you. I wasn't sure that, one might be able to say, it's an office visit plus a vaccine plus demand generation, but I just wasn't sure if you could use these unit costs for gross or macro costing for interventions as well.
I haven't used them, and I'm having a little trouble imagining how you would do that.
Great. So just to summarize then for the audience, that these costs are excellent for economic evaluation when you're trying to understand the cost offsets or the medical costs averted from a particular intervention.
Yeah.
Great.
Exactly.
That's awesome. Thank you so much. Okay, well, you all had your chance to ask a question. I have tons more, but to stay on schedule, Marcia, thank you so much for sharing this information. And we are now going to shift to our second example of costing, going to the other end of the scale, which is looking at micro costing, and Sarah will be presenting at this time. Over to you, Sarah. Thank you.
Thank you. Thank you so much, Marcia, for the presentation, and thank you, Carol, as well, for the invitation to this workshop. So as you've heard, my name is Sarah Masyuko. I am currently a postdoc at UW, and I will be presenting a case study on costing of integration of cardiovascular disease screening and treatment in Kenyan adults in Western Kenya. So in 2015, I attended the HEIST Workshop. And that was the time that I started to develop my protocol for this costing when I was doing my PhD. So this workshop has been really useful to me. So the aim of our study was to estimate the incremental cost of integrating cardiovascular disease screening and treatment into established outpatient and HIV services in Kisumu County Hospital in Western Kenya. So this was done in just one hospital, which we were working on at that time. As a background, cardiovascular disease is the top cause of death globally. And as a result, it has great economic cost to the health system because it affects people who are in the working age. And hence, they are usually very much in terms of costs to the system and also to the patients. It commonly results in catastrophic expenditures to households and leads to productivity losses since people cannot go to work either, and that resulting in absenteeism or presenteeism, meaning that they are there but they can't work fully. And we were looking at HIV and cardiovascular diseases, and it is estimated that people living with HIV have a twofold increased risk of cardiovascular disease. There are these recommendations for screening, but they are not really widely practiced. And yet there are benefits of early detection, improving life expectancy, reducing healthcare costs, and improved productivity. So that was really the motivation of our study. So the purpose of this study was to estimate the economic costs of integrating cardiovascular disease screening and in HIV clinics and outpatient departments in Kisumu County Hospital in Kenya. The target for this costing was policymakers, program managers at NCD and HIV programs, as well as clinic managers and reimbursement schemes. Kenya is rolling out the universal healthcare, so this was just a good opportunity to be able to provide some information to the program. We do present the costs, and then we look at the inputs, that's the capital, personnel, service, and patient costs. We present the intervention and then the outputs from the study. 1 minute. So in terms of our methods, we are going to use societal perspective, meaning that we, in addition to the costs that are borne by the health system, we did include the costs by the patient. That is for them to seek care, the loss of income because of that, as well as the cost of the care for the dependent and the person who's accompanying them. In our approach, we used a micro-costing approach and a time in motion survey. So the micro-costing included the cost of all resources required to integrate cardiovascular disease screening in health facilities. And the time in motion basically was estimating both the health system and patient resources use. The data was collected prospectively between June 2017 to March 2018. We sampled HIV positive from the HIV clinic and HIV negative individuals in the outpatient department at Kisumu County Hospital, a total of 598 participants. We conducted key informant interviews and direct observations, as well as expenditure report reviews and time in motion for our data sources. For our resource costs, we used the Kenya Ministry of Health salary scales, as well as using data from local and international pricing, especially for our laboratory tests, which are not maybe available locally. For the total cost, we remove all research time costs, so we gave that a proportion and removed all that from our study. In terms of the valuation and pricing, for capital costs, that is like the furniture, the space, the equipment, the staff hiring, as well as training, we did assume a 5-year useful life and discounted 3% annually, and applied an appropriate annualization factor of 4.58. All the prices are presented in 2018 US dollars. So we present the economic costs that captures the opportunity cost of time that is used for cardiovascular disease and screening that would have been used for something else by the health workers, as well as patients. We present the incremental total and unit costs for this service. The cost per person screened is the total cost, annual cost of cardiovascular disease screening divided by the total number of people who are screened. And the cost per person treated is the total annual cost of cardiovascular disease screening and treatment divided by the total number of people treated annually. The scenarios, we present 4 scenarios because we want to see how this can work in real life setting. So 1, cardiovascular screening without inflammation. In our study, when we were doing the project, we did have tests for inflammation, but in this one, because inflammation is not routinely done at health facilities, then our base case scenario is a cardiovascular disease screening without inflammation. That is just self-reported risk factors, the examinations, and basic laboratory tests. The second scenario includes inflammation, majorly using high sensitivity C-reactive protein and other inflammatory markers. And then we present a public health scenario where we say that all high-risk people who are aged greater than 45 years, who are either overweight or obese, and have no prior cardiovascular disease history would be screened for cardiovascular disease. And the last scenario, which relates to HIV, is screening all people living with HIV. So as a result, our health outcomes during the period of June 2017 to 2018, we enrolled 300 HIV positive and 298 HIV negative patients who received screening. And after that, we identified and treated 176, that is 29% of the participants. 148 of them had hypertension only, 15 had diabetes only, and 13 had both hypertension and diabetes. So from our screening, we did newly identify 55% of cases of hypertension and 65% of cases of diabetes that would have otherwise have been missed. So on to the results. This table, as well as the figure, presents the annualized total and unit cost per beneficiary for cardiovascular disease screening and treatment. And this is broken down by the implementation phase, that means either startup or recurrent, as well as the cost category. So for example, microplanning, training, personnel, and the rest, patient costs as well. So you'll see on the left, it is broken down into two. The first part is startup recurrent for screening. So we have the first part, you can see it ends at total cost of screening. That is the total cost of screening. And then we give a unit cost per person screened. So the total cost of screening only was $21,634 US, but the cost per person screened was $36.18. When you come to treatment costs, so including both the cost of screening and treatment, is $25,612, and giving a unit cost per person screened and treated, which you can see down there, is $145.52. We then present the costs either by startup, recurrent, or patient costs, and recurrent costs accounted for 93% of all our total costs, followed by startup costs at 4%, and then the patient costs at 3%. When we look at the cost per person screened without inflammation, which is our base case scenario, is $36 per person. And if we did include high sensitivity C-reactive protein only for inflammation, the cost would increase by 33% to a total of $48. If we did include all the tests that we did do for our study, it would increase the cost by 84%, meaning it would cost about $66. So I want you to remember the cost of $36 per person screened. The cost per person treated for hypertension was $164, while the cost per person treated with diabetes was $1,505. So you see the difference there is because diabetes is more expensive to treat. As well, we only identified a few patients with diabetes, and the costs are spread across all the patients. So in terms of distribution of our screening costs, how did that vary? Both the service delivery, personnel time, and recurrent costs were similar between the HIV positive and HIV negative participants. So we did not see anything different between the two. So 1.31 was the patient cost for HIV negative, and 1.24 was the patient cost for those who were HIV positive. And that was the only difference that we saw in terms of patient costs. And this was a result of some of the out-of-pocket payment of laboratory tests and medicines. The average personnel time for screening and treatment was 29 minutes. And if we were to introduce cardiovascular disease screening, this was an assumption, it would reduce the total number of people reached per day by 12.5. However, we know that there are system inefficiencies that can be gained. So that was not accounted for here. So this figure presents the distribution of cardiovascular disease cost by cost category. And you'll see that 3/4 of the economic costs are attributed to laboratory supplies and medicines. So 61% of the cost was due to supplies and 14% was due to medicines, followed by personnel, which was 14%, and then startup, patient costs, and other costs. We then did a one-way sensitivity analysis where we varied costs. For example, laboratory test costs varying between 17 and 39, and also looking at service delivery costs reduced by 12.5%. And you will notice that it's the laboratory tests that were most sensitive to changes in terms of costs. I now present the scenarios. So the first scenario, which was a high-risk screening. That means we are limiting screening to only those who are at least 45 years of age and are either overweight or obese and with no prior cardiovascular disease history. If we did this high-risk screening only, it would reduce our total cost to 12,771 for screening with a unit cost of 21.36. So this represents a reduction in terms of cost of 40%, with a cost per person screened now being at 21 as opposed to $36. The second scenario looks at screening all people living with HIV at KCH, which is Kisumu County Hospital. So if we use this high-risk screening with the available resources, it would reduce drastically the cost of startup to 0.05 because you're distributing those startup costs to a large number of people living with HIV. And hence the cost per person screened would drop to $19. However, to do so, it would cost Kisumu County Hospital $462,200 because they have a large number of people living with HIV. So the big question is $462,000 affordable to Kisumu County Hospital? It was not, because the annual budget for the hospital was $720,000, and this would then take up 64% of their allocation. So our strengths for this study, this was prospective data collection, so it gives us a real costing in terms of what is happening at that time when we were doing this. However, we have some limitations. As Marcia mentioned before, this cost was only from one facility, and hence it is not necessarily generalizable to other facilities. And also we did not calculate the cost of treatment and complications of CVD among those who are diagnosed, and hence the cost that would be averted by treatment. We only looked at treatment for 1 year. We did not estimate the loss or gains in terms of productivity losses and costs. So in summary, cardiovascular disease screening costs are substantial. As we have observed in other sub-Saharan countries, it costs about $36 if screening all individuals in Kisumu County Hospital. But this cost will be reduced by 40% if we screened only high-risk individuals, and further reduced if we screened all people living with HIV. The major cost drivers are laboratory supplies and medicines. And by integrating cardiovascular disease screening would possibly decrease the number of people reached per day by 12.5. However, this might not change if there are efficiencies gains. If we did not do screening, we would have missed 50% of cases. So we think that screening is an important activity. So in conclusion, for us, we do need to reduce the screening costs. So looking at global advocacy to harness market costs for cardiovascular disease diagnostics, looking at adoption of technology, for example, point of care tests. We also need to think about the best mix of screening. So that's part of the work that I'm trying to think about now, adapting a non-laboratory based screening method and limiting laboratory screening to only high-risk individuals where resources are constrained. And looking at financing to really generate realistic benchmarks and also look at funding support for cardiovascular disease screening. So I want to say thank you to our investigators and collaborators, our study teams on the ground, Cambridge and University of Nairobi, and the testing labs here at UW for their support, Kisumu County Hospital, and Carol Levin, who was part of my dissertation committee, and funding from the NIH, Fogart International Center, and the International AIDS and Research Training Program. Thank you so much. So I wish to invite questions.
Yes, thank you, Sarah. Can people raise your hand or type your question for Sarah in the chat box? Thank you for that wonderful presentation. And of course, any questions? This is a great example of how you can integrate costing into an existing study. Sarah's particularly interested in the integration of NTD prevention, cardiovascular prevention and treatment. And as she said, her interest was piqued when she attended a HEIST workshop and has done a great job. So do we have any questions? I will ask a question. Sarah, have you shared these results, even though, as you say, they're from one facility and one county in Kenya, but have you discussed these with colleagues in the Ministry of Health? And what, if so, what kinds of reactions and conversations have you had? We have about 2 minutes, so we'll wait for questions, but if you could maybe share some of how these data are used with decision makers.
So we did share with Kisumu County, the hospital itself, and the county director of health, looking at that. And we've also shared with the NCD department. And I cannot say necessarily how they have used it, but as they are discussing on the universal health benefit packages, I think it's being used to also look at how they can better cost for these services. But the one thing that the county director of health basically said is that when they receive funding for UHC, it is a lump sum cost, and they don't cost for all the things that they do need to do. So it was a real eye opener for them to realize that they do need to cost from the bottom up, like not always just top down. So just a mix of those.
Great, thank you. Here's a question from Beth Dunbar. I'll go ahead and read it, Beth, if that's okay with you. She says she works in digital health and is trying to think more about micro-costing applications. I'm wondering generally if you've seen good costing work for digital health. How do you see the methods being useful for that? Oh, well, thanks. I think I could probably answer that. In fact, we have wonderful costing in digital health here in the Department of Global Health. Work by Allison Drake and Jen Unger on something called Mobile Watch, using one-way and two-way text messaging to increase ANC participation and adherence to HIV. So Beth, we can, if you follow up and email me, we'll share with you some work that's been published by Yilin Chin, who's actually a PhD student in the Department of Pharmacoeconomics now. So yes, we can use these costing methods there. Another question from Dorothy is, how did you handle hiring costs incurred prior to the intervention? Or did you consider these recurrent? That's for you, Sarah.
So we looked at, so when we were doing this, we looked at how we did the resource cost. We looked at how long does it take to see a patient. So the time in motion was helpful to do that. And then we used the Ministry of Health costs for that. And then we did that. But in terms of hiring costs, because we assumed that these are Ministry of Health staff, we did not include the cost for hiring, for example, if we are hiring for a study. So that is not included because it's not part of our program, but necessarily costs. Those are costs already taken care of.
Does that answer your question, Dorothy? Thank you, Sarah. Yeah, great. Okay. Well, you can still type your questions for Sarah in the chat box and she can respond. To stay on schedule, we're going to go to our next presentation. We're now shifting from how are costs used? You've seen two examples of how costing has been used for assessing integration. You've seen how costing can be used to support economic evaluation. I'm going to start to talk about a budget impact and assessing affordability, since in fact, Sarah raised the issue that despite it being an essential service, in fact, it wasn't affordable to a particular county in Kenya. So I'm going to go ahead and start my presentation. I would love some feedback, verbal feedback on what screen you're seeing, please.
So we're seeing your notes.
Okay, no problem. You would think I would have figured this
Good.
out by now.
Now
but
we're
I
seeing
haven't.
it.
Okay, great. Wonderful. Thank you. Okay, so we're going to, before our final presentation by Mita Sahu, we're going to look at what is a budget, that should say budget impact assessment, apologies, and how do you assess affordability? So without further ado, let's get going on that. A budget impact analysis is how a government can assess the affordability of a new technology or a prevention. So as we saw in the case of looking at integration of cardiovascular screening or treatment on ongoing health services in Kenya, in fact, there may have been a study demonstrating that screening and treating for cardiovascular disease prevention is cost effective. And in fact, there are many studies to demonstrate that. But is it affordable when you get down to the nuts and bolts? Can you introduce it and scale it? And so BIA's budget impact analysis or assessment helps to assess the affordability. Now there are many other ways to assess affordability for smaller studies, and we'll go through those. And in fact, we will kind of, if time permitting, look at patient costs, which is a big consideration of affordability. Sarah mentioned that given that out-of-pocket expenditures can be quite high for those individuals that suffer stroke or heart attack or acquired diabetes. So the issue of affordability actually remains high on health policy agenda. In fact, I was just reading a report that indicated that despite the fact that global health expenditures account for 10% of GDP worldwide, those expenditures have plateaued, right? And so countries have made their commitments, and yet we don't have enough resources to introduce and scale life-saving and essential interventions. So determining whether healthcare services are affordable depends on the concept of affordability. And of course, that takes into consideration what governments can spend annually, if you're talking about governments. And of course, if you're talking about households, that would be what does their household income and what does the cost of care. So we're going to first focus on affordability to a government, not affordability to an individual. So the most formal type of government assessment would be a budget impact assessment. This hasn't to date been done much in low and middle income countries, but it's gaining popularity. In a moment after we look at BIA, we'll explore these individual approaches that can compare the cost of a technology, let's say, or a new vaccine to what the country's already spending on health. And we can also compare an intervention cost per person to the total expenditure on health per capita. So these are ways that governments can also assess affordability. So for budget impact assessment, what is a budget impact assessment? It uses a lot of the same data we'll see in a moment that economic evaluations use. It estimates the expected changes in the expenditure of a healthcare system once a new intervention is scaled up nationally. It contributes to budget and resource planning. So the intent of a BIA, the use of cost data, is for budgeting and resource planning. And of course, I've already said it addresses affordability. And it often is used in conjunction with information on cost effectiveness. So you may have a study that, an RCT perhaps, that demonstrates that an intervention is effective. You may have, in fact, modeled cost effectiveness. And now you can use much of the same data to assess, to conduct a budget impact assessment. So who uses a budget impact assessment? Obviously, individuals who manage and plan healthcare budgets. This has become much more popular in the United States. It's probably an essential part of a health technology assessment package in countries that where the government covers healthcare costs. They would need to also conduct a BIA. So many high-level national, regional, global entities use it, as well as private health insurances companies. So what aspects are considered in a BIA? Many of the same that are used in costing and in cost effectiveness analysis. We have to understand the features of the healthcare system. You have to clearly state what the perspective is. Is it a donor? Is it a government? Is it the health insurance payer perspective? You need information on the use of current and new interventions. Now, in low and middle income countries, we're often introducing a brand new intervention. This is becoming less and less the case, but until recently, we often were actually introducing new interventions, or at least new delivery strategies for interventions that have not yet reached the populations they need to reach. So you need information on your eligible population. You need to be able to describe and know coverage levels of your current intervention, the uptake, the potential uptake of a new intervention, the market effects. For drugs, you would need off-label uses or technologies, and you would need the cost of the current intervention and the new intervention mix. You'd also need information on impact, time horizon, time dependencies and discounting. You would have to choose some kind of computing framework. Could be Stata, could be Excel, and you'd have to, like in economic evaluation and costing, you'd have to conduct uncertainty and scenario analysis, and you'd want to validate your results. So here's a visual on what you're doing. You're looking at that on the far left. You can imagine your current situation, your total population, who's sick for the particular condition you're looking at, your target population, who you want to either prevent illness or treat differently, the resource utilization and costs, and then the cost of illness, which is, of course, the cost to the household or the cost to society. And then you're going to look at how does this new intervention change the incidence or prevalence, so that now what's your new population, what's the new share that's sick, who's the new population, right? So you're assuming that this new intervention shifts the environment, and you need to characterize that environment as well. So what types of data are needed? You need to, in order to understand the cost per patient, you need to understand the probabilities, treatment patterns, costing information, and this is where our cost information on resource use, prices, and tariffs of if you're importing technologies or equipment, the number of patients, the proportion of patients that are eligible. I won't go through this list, but you can see that there's a lot of information need in a classic BIA. So you might be asking yourself about this time, well, then what's the difference between a BIA and an economic evaluation? Well, budget impact assessment should be viewed as complementary to economic evaluation, not as a replacement to it. Where economic evaluation evaluates cost and outcomes of alternative technologies over a specified time horizon to look at economic efficiency, right? So are we allocating resources to maximize social welfare or to maximize technical efficiency across a range of choices? Budget impact assessment addresses the financial stream of consequences related to the uptake and diffusion of a technology that you've already decided on, right? It doesn't need to be comparative, only in the sense you're comparing it to what did exist before. And the aim is to truly assess the affordability, right? So economic evaluation is looking at economic efficiency, and budget impact is looking at affordability. They share many of the same data elements and methodological requirements. However, there are important differences in the data and methods and how these are incorporated. So let's look at a few of these now. Again, I've already mentioned that the concept is different. BIA is affordability. Economic evaluation is value for money. The objective drives everything you're doing when you're designing a costing study. So the objective is financial impact of introducing a technology, where the objective is economic efficiency of alternative technologies. Remember, in economic evaluation, it's a comparative analysis. The study time frame may be different. If you think about HIV prevention and treatment, you're looking at that over the course, the life course of an individual. Similarly with cervical cancer prevention. But for BIA, you're really looking at what is the Ministry of Finance or Ministry of Health budgeting time period, and that's often done in a 5-year period. We don't necessarily need to focus on health outcomes in a budget impact assessment. We need some of the same indicators to understand the incidence so we can get to numbers treated, but health outcomes are excluded. Health outcomes are critical for economic evaluation. And you can see that the perspective is different and typically in a budget impact assessment, a BIA. I say assessment analysis, so the A can be whatever you like it to be. So the comparison is different scenarios for scaling up in a given population, whereas economic evaluation is comparing different technologies or interventions to achieve the same health outcome, and should technically, but never is, look at the full range of options, right? Study population that are different. You have an open cohort for BIA, a closed one. Discounting is not necessarily needed in a 5-year period for BIA, but it is recommended, discounting benefits and costs in economic evaluation. And then we present total and incremental annual costs in BIA, but we look at an incremental cost per health outcome achieved. Maybe it's a QALY gained, could be a death averted or a DALY averted. And in terms of generalizability of results, they're not really generalizable because it's very specific to a particular country and a particular intervention or technology being introduced in that country. Whereas, of course, we know that economic evaluations are typically, if done well and following best guidance practices and are of high quality, can be generalizable. What is the budget? What is the budget impact methodological specification? Again, it should be the specific methods are relevant to the decision maker's problem and the objective. So it's really important to clearly state that. And that is true whether you're doing cost effectiveness, or BIA. And then again, you would disaggregate and reflect the cost depending on what the question is. Do you need to show it for the government and social insurance budgets? Do you need to focus on household and out-of-pocket payments, the impact on that, or third-party payers or external donors, right? So it really depends, again, how you set up your analysis. I'd like to now turn to some other ways that you can actually assess affordability. Well, I'm going to show you some other ways to assess that affordability has been assessed in the literature, and then share with you some ideas that you can hopefully incorporate in your own future studies. So this is so again, BIA is one way to look at a very specific issue around affordability. What you're looking at now is another way to assess affordability of new technologies across a set of countries. So what you're looking at is a graph that compares the cost of GeneXpert for multi-resistant tuberculosis, for diagnosing that, to the cost of that to the funds that the country is already spending on TB care and control and on HIV prevention and treatment, right? So it's similar to what Sarah did. She looked at the costs of introducing screening for cardiovascular disease to the overall hospital budget and found that that wasn't affordable. In this case, they're looking at this rapid test to diagnose tuberculosis and looking at the cost as a share of what is already being spent. And what you can see is that those costs in areas where TB burden is quite high get become very high early on. And so for all people with TB signs and symptoms, that cost could represent 10% of annual funding and TB care and control in those high burden countries in Europe or Brazil and South Africa. But those costs become negligible in areas with lower burdens. In most of the TB high burden countries in Africa and Asia, those costs represent 20% of TB spending and much higher figures of 80% in India, Bangladesh, Indonesia, and Pakistan. And in part, that's because their budgets are already very low. So this is one of the ways where you can assess affordability, and then really it is a signal to TB policymakers to identify ways to to bring down these costs, to look for ways to for further price reductions and to increase affordability. Then another way to think about in individual studies of, for instance, if you're doing a cost effectiveness analysis, you could also look at comparing the intervention cost to healthcare spending in a particular setting. So this is a data from a 2009 analysis on cost effectiveness of rotavirus vaccine in Vietnam. In 2005, and those data aren't up, but I'm just giving you some background, there was actually an analysis of cost effectiveness of rotavirus vaccine in Vietnam by Fisher et al. And they assumed that the vaccine price was $1 to $20. They found that at $5 a dose, the cost per dollar averted was $87 per dali averted. And in 2005, Vietnam's total expenditure on healthcare was $21 per capita. And so of this, the per capita expenditure on healthcare was $6. So you could see that the authors felt that in 2005, HPV vaccination, rotavirus vaccination would not have been affordable given competing demands on healthcare. But then 4 years later, a 2009 study on rotavirus indicated that in fact the cost per dali averted, it was 540 per dali averted, and which was less than Vietnam's GDP per capita, when they assumed that the vaccine price was $5 a dose and children had to get 2 doses. They estimated that that would be about 18 million per year for a population of 86 million, and of course just vaccinating kids, and that would be about 20 cents per dose. And at that price, it was less than 1% of what the government was spending by 2015. You can see that a couple things happened. Health expenditure per capita went up, and the government's share of it also increased. So it's interesting to see how things can change in a very short time period. And part of what happened was improvements in the model, improvements in the impact of rotavirus vaccine over time that made it more cost effective. And then of course also the budget increasing in Vietnam as their income grew. So let's see, I want to make sure I'm on schedule. I think I have till 10:40. If please speak up, maybe Danielle, if I misread that. So we do have some time to go to look into patient costs, which I think is also really interesting. Patient costs measure out-of-pocket expenses. They measure lost income. They measure lost income associated with missing work, but also with health-seeking behavior. And this is also often critical in low-income settings where households and individuals are working in agriculture or the informal sector. A day missed of work is truly a day without income. So typically we need to understand household income to understand patient costs. We need to know what percentage of health care costs are a share of household income. Now, that's easier said than done. Measuring household level income is classically challenging. We often use proxies like expenditure, so that's its own methodological can of worms, but there are some nice papers out there on measuring income. But assuming that we in fact have information on income, or we make assumptions about what daily income is based on a daily wage rate in a country, then we can start to get some ideas about whether or not individuals can afford treatment. So this is from a paper by Kemp et al. Malawi's poor afford free tuberculosis services. And even though the services are free, they explore the impact of accessing services on patient and household costs. And so as a setting in Malawi, at the time that this study was done in 2007, average daily income was about 71 cents per day in urban, 21 in poor urban, and 123 in non-poor urban. And the percentage of a household's income spent on food varies from 60% in the poor households to 30, right? So it doesn't leave a lot of income for other things. So even when TB treatment is free, there are costs incurred by patients, and you can see here that these are for smear negative and smear positive, and these costs to the patients depend on how many visits do they have to seek for screening prior to treatment. In the case of smear negative, it's actually close to 6 visits. Smear positive, it's 4.5. They are responsible for fees and drugs. Transport costs can be, not significant, but do contribute overall. Food costs. And so the total direct cost of out of pocket for smear negative for 6 visits is about $17. And let's say they do this once in a year per year, or $9, but maybe they have to go, maybe they seek care more frequently than a year. But nonetheless, in the moment, these costs are barriers to seeking care. And of course, the number of days lost are anywhere from 19 to 24 days, and that's lost income. So cost-effective interventions may not be affordable to governments, and even when there's free health services of cost-effective interventions, these may not be affordable to poor households. So additional resources for really great guidance on conducting budget impact analysis is from Sean Sullivan, who's actually a professor in our School of Pharmacology, and Joseph Maskow. So these are great resources for starting to think about your own work. So let me stop there and see if we have any questions. I'm sure I was perfectly clear. Any questions? We could be ahead of time, and then we can have some time to discuss afterwards. So with that, I'd like to turn it over to Mita. I introduced Mita earlier. She's a second-year grad student, but Mita, feel free to further introduce yourself for people that came late.
Great. Can everyone see my slides?
Yes.
Great. All right. Well, thank you, Carol. I'm Mita Sahu. I'm a second-year PhD student in global health metrics, and I'll be presenting on cost-effectiveness analysis using mathematical models, using an example from some work I did with Ruanne Barnabas's group evaluating community-based HIV care in South Africa. And this is an example of the type of analysis we can do with costing data, including cost effectiveness analysis and budget impact analysis, which Carol just discussed. And with this research, we want to answer a policy question of what is the cost effectiveness and affordability of scaling up community delivery of HIV care in KwaZulu-Natal, South Africa. And that's a province in South Africa which has a high HIV prevalence of 27%. There are many ways to approach economic evaluation, but this is the flow that we've followed. First, we define what we want to measure. So what is the end goal of what we're trying to estimate? And next, we need to know the effectiveness and the costs of the intervention within the trial context. And after that, we can estimate the population impact using mathematical modeling. And then using the outputs from the microcosting and the mathematical modeling, we can estimate the costs of the intervention at scale, as well as the affordability. And finally, we combine these total costs with health outcomes to estimate cost effectiveness. So as you can imagine, the process here from the very beginning to the end can take many years. So it's definitely a group effort. Let's start with defining our outcomes. So in terms of health outcomes, a really commonly used metric for economic evaluation is the disability adjusted life year, or DALY, which is a metric that combines both the years of life lost or the premature death and the years of life lived with disability, which tells you about both the severity and the duration of the disease. So essentially, DALYs are bad, they represent health loss, and we want to avert DALYs. So to estimate DALYs, we need to make some assumptions. First, we need to decide on a life expectancy to compare with, so we know what counts as a premature death. For our analysis, we use a life expectancy of 80. Second, we need to agree on how much disability you're incurring for each health state. And IHME publishes these standardized disability weights, which are very commonly used. And you can see here for HIV, they vary based on treatment status and CD4 count. The end goal of our economic evaluation is to come up with a standardized estimate of how cost effective the intervention is, which we can then compare against other interventions or against a threshold, which tells us whether the intervention is worth pursuing. The standardized outcome that's used is the incremental cost effectiveness ratio, which is the difference in costs between our intervention and standard of care divided by the difference in health outcomes between the intervention and standard of care. And then our final result will be presented as a cost per DALY averted. So for South Africa, we have an established cost effectiveness threshold for HIV interventions, which comes from this 2017 HIV investment case. So for an HIV intervention to be cost effective, it needs to cost less than $750 per DALY averted. Great, so now that we know what we're trying to estimate, let's go through the process of estimation. First, we'll go through the trial where we actually evaluated the effectiveness and costs of the intervention. The DO-ART study is a randomized trial in South Africa and Uganda, which evaluated the effectiveness of community delivery of HIV care using mobile vans. These results were recently published in Lancet Global Health and found that community ART improved viral suppression among men, increasing it from 51% to 72%, while for women, viral suppression was already high, so it just improved it marginally. And as part of the DO-ART study, the cost of delivering community ART was also estimated using microcosting. Specifically, the costs were measured using a health system or provider perspective to estimate financial costs. And because the standard of care clinics weren't really enrolled as part of the study, it wasn't possible to do microcosting for the standard of care. So microcosting was only done for the intervention. But for South Africa, there are standardized cost estimates for HIV care, which are available from the literature. So that was used for comparison. And the annual costs were estimated in 3 ways. First was the observed costs, which excludes research costs, but it does use the research staff salaries. And second was a programmatic scenario, which substituted in the typical Ministry of Health salaries for the research staff salaries to mimic a programmatic setting. And the third was an efficient at scale scenario, which used time and motion studies to estimate an efficient client volume if the program were actually scaled up and what the costs would be under these conditions. And the results of the microcosting study show that while the observed and programmatic costs were higher, if the program is scaled up, the costs would be around $245 per year after the first year of the program. And this is comparable to the values seen in the literature for clinic-based care, which is $249. So now that we know the effectiveness and costs within the trial setting, we use mathematical modeling to estimate the population impact at scale. And at the previous HEIST workshop, Kara Bayer presented on our mathematical model. So hopefully you were able to see that, but if not, I'll try to recap quickly. Using our mathematical model, we estimated the population impact of community ART on HIV incidence, prevalence, and mortality for the entire province of KwaZulu-Natal. And this population in the model includes adults aged 15 to 79, and we track the full population over time from 2020 through 2060. And we compared 2 scenarios. The first is the standard of care clinic scenario, and the second is the intervention scenario, which includes clinic-based ART for everyone who's already reached by standard of care, plus a testing campaign once every 5 years, and then community delivery of HIV care for people who newly test positive in this campaign. And the results of the mathematical modeling show that among men, within the first 5 years, there was already a 40% reduction in population mortality. And among women, there's a 35% reduction in new infections in the first 5 years, likely because the increased viral suppression among men then led to a decreased transmission to women. So now that we have our estimates of population incidence, prevalence, and mortality, we can estimate the costs and affordability at scale and over time using the cost modeling and budget impact analysis. This is a map showing which outputs from the mathematical model get used as inputs for our health economic analysis to estimate costs and DALYs. And really the main thing I want to highlight here is that we don't just use the information on cases and people on ART and CD4 to estimate health outcomes. We also use it to estimate the costs, because our total cost at scale includes things like treatment costs, which depend on the number of people with HIV who are on treatment. So we're using the model outputs to estimate both the total costs and the health outcomes. We then apply the cost parameters that we have from the microcosting study as well as from the literature to our population. For the standard of care scenario on the left, we're assuming that people enrolled in clinic-based care have an annual treatment cost of $259. And in this scenario, the people with HIV also incur hospitalization costs, which vary depending on the CD4 count. And in the intervention scenario in the middle here, we have the same people who are enrolled in clinic care, but then there's also a mass testing campaign, which achieves 75 coverage. And we apply a cost of around $6 per test to each person tested. And then the people who test positive in the campaign are then initiated on community ART, which costs $255 per year after inflating to 2020 US dollars. And we, and again, these people in this scenario, we also have hospitalization costs for all people with HIV. And This allows us to estimate the affordability, the total cost of ART and the affordability. So we see that in the first 5 years, the incremental program cost for the intervention is $43 million per year. And we know from the published South African Consolidated Spending Report that the actual HIV budget for KwaZulu-Natal is $312 million. So this means that an additional 14% initial investment is required for scale up. And just to display what our costs actually look like in our standard of care scenario versus the intervention over time, we can see that the per capita annual cost starts at around $55 for clinic ART on the left, and on the right, it starts at around $60 per person for community ART. And in both scenarios, the costs come down over time because of reduced HIV prevalence. However, the decline is steeper in the intervention scenario. And in both scenarios, the bulk of the costs come from the treatment costs, which are in green, with a smaller share from hospitalization costs, which are in blue. And finally, in the intervention scenario, there are these spikes every 5 years, which are from the testing costs from the testing campaigns. And now that we've estimated the total costs and affordability at the population level, we can combine the costs with health outcomes to estimate the cost effectiveness of the intervention. So in the end, after all this work, we get a very simple table, which helps to answer our policy question of whether it's cost effective to scale up community ART for one province in South Africa. And we estimate that the total cost of the program is an additional 1.68 billion over the 40-year period. And in terms of health outcomes, it averts 9 million DALYs. And then in terms of cost effectiveness, we divide these two numbers and find that incremental cost effectiveness is $187 per DALY averted. And then we compare this to the cost effectiveness threshold for South Africa of 750 per DALY averted for HIV interventions. And we find that our cost effectiveness, it's well below the threshold. So this is a highly cost effective intervention at scale. And now we've made it through all the steps of our analysis. With the help of the mathematical modeling, we could talk not just about effectiveness on viral suppression within the context of the trial, but also the population impact on incidence on mortality. And then we could estimate the cost effectiveness and affordability at scale. So in conclusion, we found that in terms of population effectiveness, community ART prevents over a quarter of cases and deaths over time. Scale up is affordable, but requires an additional 14% initial investment. And scale up of community ART is highly cost effective at $187 per DALY averted. And we've reached the end. I want to acknowledge my colleagues who all contributed to different parts of this analysis, in particular, Alan Roberts, who led the costing, and Kara Bayer, who led the mathematical modeling. And thank you all for your attention.
Thank you, Mita, for a wonderful, comprehensive presentation of the kind of work that we've been supporting here in HEIST. This presentation, as well as Kara's presentation last week, really is a great example of sort of the systematic process. And I think everybody's mentioned, all of our speakers have mentioned today, that this work takes time. I remember when I first, before I came to the University of Washington, I worked at PATH, and I hadn't been working in health economics, and I was getting to meet teams, and they were inviting me to come onto their team to do cost effectiveness analyses. And they're like, do you think 3 days will be sufficient time? And I knew that sounded wrong, but I didn't know. So by the third year that I worked there, I decided that I would never do a cost or cost effectiveness study with less than 30 days of my time. I've gotten better at it, so now I can put it down at 10 or 20. But anyway, all that to say, all this work takes time, and I think you've shown us, all of our speakers today, how much time that takes. I'd like folks to open this up to ask questions. Your questions help us to highlight other facets of this work. So I'll pause for a moment, and I do have a question for all the speakers if you don't, but I'd rather hear from our workshop participants, please. And don't forget to meet, hey, Jesse, yes, please unmute yourself though. Thank you.
Yeah, so you said it would take a 14% incremental investment, and that was deemed affordable. What was your sort of threshold for calling that affordable? Because 14%, that's not negligible.
Yeah, we actually, I mean, we haven't used a threshold for affordability. Our threshold that we've compared to is from the cost effectiveness analysis. So really, yeah, the focus of our analysis was in the cost effectiveness estimation. And for that, when we include the health outcomes, we really find that it is well below what we would want to, yeah, that it would be much more cost effective than interventions that are already being implemented. Yeah, I don't know if there are thresholds if Carol knows about thresholds that are available for budget impact analysis.
Yeah, it's not necessarily, because again, it will be context specific. It will depend on, so, you know, of course, all of this, everything we've been presenting today, these are 3 pieces of information: cost effectiveness, budget impact assessment in a decision maker's priority setting, and they consider lots of other things. So there is no threshold. If there's political will, if it's a first lady's pet project, there are many things that go into accepting and scaling an intervention. So no, there are no thresholds for BIA that I'm aware of.
Just a
Go
quick
ahead.
follow-up. Did you discuss this budget impact with anyone in like the Ministry of Health or Finance in KwaZulu-Natal to get their sense of whether that seemed affordable or not?
So we haven't yet done that, but they are actually, so this trial was done, it wrapped up last year, and the Ministry of Health there has actually started scaling up this intervention. They have started doing community ART, and Ruanne Barnabas, who led the trial, she has a very close relationship with the ministry there. So I think there is a plan to work with the ministry, but we haven't yet done that.
Thank you.
Other questions for Mita or other panelists today, workshop presenters? One question I have for, I did have a question. I thought it was a really good one and I may have forgotten it. I guess it might be, yeah, go ahead.
This is Yang Fang, and I do have a question for Marcia. Thank you for your presentation. And you mentioned that, like, for the costing, a unit cost, there is the unit cost by course for 2 countries. Could you specify or elaborate a bit about those 2 country cases?
Sure. So Joe Dielman has produced cost estimates for inpatient visits, inpatient admissions and outpatient visits for the United States by cause. And then I've actually, I don't know if Australia has them by cause, but they at least have a national estimate of an outpatient visit and an inpatient admission that were comparable to what I presented. The NHS for England has some, but it's they're not aggregated in the same way.
Great, good to know. And then for inpatient services, currently the utilization unit is admission. Is there any unit cost for the bed days, which take into account of the duration?
No, it doesn't take into account the duration. So for many countries, the length of stay varies quite a bit. You can have lengths of stays of a week or several weeks, whereas in other countries, it can be often only a matter of days. But we don't have a estimate by length of stay.
Good to know. Thank you.
Yeah, just in comparison, the WHO choice assumes a 7-day length of stay for all countries. Whereas for me, I'd rather just estimate per admission than to introduce information that's inaccurate for a length of stay.
Great. Yeah, I think, for example, for the TB patients, especially the multi-drug resistant TB patients, and then the assumption of 7-day stay would be unrealistic, and that's why, like, currently we are pounding on whether there is the cost estimation based upon that day. Great.
Yeah.
Thank you, Marcia.
You're welcome.
Do we have other questions for our presentation presenters? Okay, well, you know how to reach us. You can send emails to any of us to follow up. Please visit the CFAR website. The link is in the chat box. You can access the presentations from this workshop and others. And if you are a faculty, staff, or graduate student interested in incorporating this kind of work into your own work, please reach out to HEIST. We're here to point you in the right way, to provide some support. We often joke that we're the third aim of NIH grants. We always are at the bottom. They rarely fund a purely economic study. So we're your third aim team if you are writing grants, and we're here to support your work. And we will be offering, starting next fall, some new workshops, maybe one on behavioral economics, and diving into some more work of members of our HEIST team. So thank you so much for joining. Again, thanks to our participants who all did a great job, to our workshop presenters. Thank you so much.
Bye.